Welcome back to the Deep Dive. We are glad you're here because today we are opening a file that is, to put it mildly, dense.
That's a big one.
Yeah, it really is. We're tackling a topic that sits right at the intersection of immunology, oncology, and some really high-stakes decision-making.
Absolutely.
We are talking about the lymphatic system and specifically what happens when that system, which is designed to be your body's elite defense force, decides to, turn against you.
We're talking about lymphomas.
We are.
And it is a massive topic. I mean, honestly, looking through the research and the clinical guidelines we have in front of us, it is so easy to feel like you are just staring into an abyss of terminology.
Oh, for sure.
You start reading and you get hit with all these acronyms. ABVD, CHO, B copy, NFB.
It looks like an encrypted code.
It does. But our job today is to crack that code, to make sense of it all.
And it's not just one disease, right?
Yeah.
I think that is the biggest misconception we need to clear up right at the very start.
That's probably the most important point.
The source material refers to this as a heterogeneous group of malignancies.
Which is the polite medical way of saying it's complicated.
Right. It's a massive umbrella term.
A huge umbrella. We are talking about cancers that arise from immune cells, specifically lymphocytes that live in your lymphoid tissues. But the way, say, a Hodgkin lymphoma behaves is fundamentally different from a diffuse large B-cell lymphoma.
They're different beasts entirely.
Completely different.
So the mission for this deep dive is pretty clear then. We need to parse out that classification, what we are calling the Great Divide. We need to understand the biology of why these cells go rogue in the first place.
And then we need to get into the trenches of treatment.
Exactly. Because the history of treating lymphoma is actually a history of modern oncology itself. It's this constant balancing act between the cure and the cost of that cure.
That's a great way to put it. It's a story of sledgehammers versus snipers. Yeah. And the stakes just couldn't be higher because, as we'll see, we are so often treating young people in their 20s and 30s. And the intent is to cure, not just, prolong life.
So let's start at the very beginning, the Great Divide. You have Hodgkin lymphoma on one side and non-Hodgkin lymphoma on the other. It sounds like a rivalry.
It basically is. Historically and pathologically, this is the first fork in the road. If a patient comes in with an enlarged lymph node, the first thing that happens is a biopsy.
Okay.
The pathologist puts a sample under the microscope, and what they see, or what they don't see, determines which path we go down.
And they're looking for one very specific thing to diagnose Hodgkin lymphoma.
One very specific, very famous cell.
The Reed-Sternberg cell.
Correct. The malignant Reed-Sternberg cell. In the literature, it's often described as having this owl's eye appearance.
Owl's eye.
Yeah, they're these big, often binucleated cells, and they look like a pair of owl's eyes staring back at you from the microscope. If you see those, you're in Hodgkin territory.
And if you don't?
If you don't, you are very likely dealing with some form of non-Hodgkin lymphoma, or NHL. It's as simple as that at the first step.
Okay, so let's drill down into Hodgkin lymphoma first. What is actually happening inside that Reed-Sternberg cell? Because the notes mention a disruption of B-cell transcriptional processes. That sounds like a software error.
That's a fantastic analogy. It's exactly like that. Imagine a B-cell, which, is an immune cell designed to make antibodies.
Right, its whole job is to fight infection.
Exactly. But this B-cell suddenly forgets its job description. The transcriptional machinery, the code that tells it you are a B-cell, express these B-cell markers, make these immunoglobulins, that machinery breaks down.
So it's just lost.
It's lost its identity. So these Reed-Sternberg cells, they're essentially B-cells that have become ghosts. They stop expressing their surface markers. They stop producing the mRNA for immunoglobulins. They are ghosts of B-cells.
Ghosts that refuse to die.
Right. And that is the really dangerous part. They overexpress a specific protein complex called nuclear factor kappa B.
Or NFLA.
NFLA.
I highlighted this in the notes. NFT seems to be the main villain here. What is its function in a healthy cell versus in one of these cancer cells?
Well, in a healthy context, NFKB is a critical signaling pathway. It's involved in the immune response and inflammation. It's a good guy.
Okay.
But in these cancer cells, it acts like a jammed on switch. It's just stuck in the on position.
And what does that on switch do?
Two things. First, it drives cell proliferation, so the cells just keep dividing and dividing. And second, and this is crucial, it sends powerful anti-apoptotic signals.
Apoptosis being programmed cell death.
Exactly. Our cells have a built-in expiration date or, a a self-destruct mechanism if they get damaged. And as key just overrides that completely. It tells the cell, no, don't die. Keep living. Keep growing.
It's an immortality switch.
It's basically an immortality switch.
So what flips that switch? Is it a random genetic mutation? Is it something in the environment?
This is where it gets like a detective novel. The sources point very, very strongly to a viral connection. Yes, specifically the Epstein-Barr virus, or EBV.
The monovirus. The kissing disease.
The very same. In a significant percentage of Hodgkin cases, we actually find EBV genetic material inside the tumor cells themselves.
Whoa.
And the theory is that the pathogen itself, the virus, upregulates NFPB to keep the host cell alive.
So the virus can keep replicating.
Exactly. It creates a safe house for itself. But in doing so, it accidentally sets the stage for this malignant transformation.
So it's not the cause in every single case,
But the correlation is far too strong to ignore. It's a major, major risk factor.
that is unsettling. I mean, most of us have had EBV at some point in our lives.
It is. But you have to remember, obviously, most people who get mono do not get lymphoma. It takes a sort of perfect storm of that viral trigger and some underlying host susceptibility.
Okay, so you've got this cellular rebellion happening at the microscopic level. How does that actually translate to the patient, the person sitting in the exam room? What brings them in?
Usually it's the lump.
It's just a lump?
Almost always. A painless, rubbery, enlarged lymph node. And painless is the really key word here.
Why is that?
Because an infection, like strep throat, gives you swollen nodes that hurt. They're tender. Cancer very often doesn't, at least not at first. It's just there.
And with Hodgkin lymphoma, the location is highly specific, isn't it? It tends to be supradiaphragmatic.
Yes, that's a classic feature. It's usually above the diaphragm.
So we're talking neck, chest.
Neck is very common. The supraclavicular area, which is right there above the collarbone or the mediastinum.
The space in the chest between the lungs.
That's right. You might also find it in the axilla, the armpit. But it is much, much rarer to find it starting in the groin or below the belt, so to speak. It has a very predictable pattern of spread.
But it isn't always just the lump, right? The notes discuss these B symptoms, and frankly, these sound absolutely miserable.
They are, and they're prognostically very important. In lymphoma staging, we actually append the letter A or B to the stage number.
Like stage IA or stage IIB.
Precisely. A means you feel fine other than the lump. You're asymptomatic. B means you have these systemic constitutional symptoms.
And what constitutes a B symptom? What's the official list?
There are 3 specific things. First, an unexplained fever, usually over 38 degrees Celsius or 100.4 Fahrenheit. Second, drenching night sweats.
And what does drenching mean in this context?
It's not just feeling warm. We're talking about soaking the bed sheets, soaking your pajamas, needing to change in the middle of a night. It's profound.
I don't know.
And the third one is significant weight loss. That's usually defined as losing more than 10% of your body weight over a 6-month period without trying.
And that's the body reacting to the cytokine storm from the cancer, I assume.
That's exactly what it is. It's this massive inflammatory response. About a quarter of Hodgkin patients, so 25%, will have these symptoms at diagnosis.
And if you have them, it changes things.
It puts you in a different prognostic category right away. It's a sign that the disease is more aggressive or more systemic.
Okay, so the patient comes in with the lump, maybe the sweats.
Yeah.
You suspect Hodgkin.
Yeah.
You do the biopsy. You see the Reed-Sternberg cells. Now you have to stage it. How do we map the battlefield?
Staging is a 2-step dance, really. First, you have what's called clinical staging. This is all the non-invasive stuff.
There's no cutting.
No cutting. We take the patient's history, do a thorough physical exam, run blood work, and most importantly, we do radiography. The gold standard now is the PE scan.
That's the one that lights up metabolic activity.
Yes, cancer cells are they're hungry, they eat a ton of glucose, so we inject a radiolabeled glucose tracer, and the cancer cells light up like Christmas trees on the scan.
So you can see exactly where the active disease is.
It tells us everything. Which node groups are involved, if it's in the spleen, if it's in an organ. It's an incredible tool.
But the text also mentions pathologic staging, which sounds sharper.
It is. Pathologic staging is invasive. And honestly, this is largely historical now, but it's important to understand. It involves taking biopsies from strategic sites to see if the cancer has spread microscopically.
Like where?
Well, we're talking about checking muscle, bone, skin, the spleen, abdominal nodes. In the old days, they would actually do a laparotomy.
They'd cut open the abdomen.
They would, just to stage the disease. They'd cut open the abdomen, take out the spleen, and biopsy all the lymph nodes just to check them.
That seems so extreme by modern standards.
It was. With the advent of PET scans, which are so sensitive, we rely much less on surgical staging. But the concept is the same. We need to know if it's local or if it's systemic.
And what do the numbers usually say? Is it typically caught early?
Actually, yes, and this is the good news. About 50% of patients present with localized disease. That's stage 1, which is one node region, or stage 2, which is two regions, but on the same side of the diaphragm.
And how many are advanced?
Only about 10 to 15% walk in the door with stage 4, which is disseminated disease involving organs like the liver or bone marrow.
So that brings us to the really big question. Survival. Hodgkin lymphoma is often touted as the success story of modern oncology. Is that accurate?
It is, without a doubt. If you are a young patient with early stage or limited stage disease, your cure rate is somewhere between 90 and 95%.
That is an incredible number for a cancer.
It is staggering. It's one of the most curable cancers there is. Even with advanced disease stage 3 or IV, we're still seeing cure rates of 60 to 80%.
It's still really good.
It is. Now, age is a big factor. If you're over 65 or 70, those numbers do drop significantly, partly because older patients just can't tolerate the harsh treatments as well. But overall, Hodgkin is a highly curable cancer.
But, and here's the pivot point of our whole discussion, cure is a heavy word because the road to that 95% number is paved with some very, very intense chemistry.
It is.
So let's move into section 2, treating Hodgkin lymphoma.
This is what we call the balancing act, because we know we can kill the cancer. The challenge is, can we kill the cancer without destroying the patient's future quality of life?
Right. And like you said, we're often treating people in their 20s or 30s. They have another 50, 60 years of life to live. We don't want to ruin their heart or their fertility in the process of curing them.
Exactly. So the main weapons in the arsenal are radiation therapy and chemotherapy. Surgery really only plays a role in the biopsy. You can't cut out a systemic lymph disease.
Let's look at radiation first. The trend here seems to be less is more.
It is. Historically, we use something called total nodal irradiation. We basically radiated all the lymph node chains in the body from the neck down to the groin.
Wow.
It worked, but the long-term toxicity was massive. Then we moved to extended field radiation, and now we're largely at involved field radiation.
So you just target the nodes that are lighting up on the PT scan.
That's it, precision bombing versus carpet bombing.
A much better analogy.
And usually radiation isn't used alone anymore. It is almost always paired with chemotherapy. And this is where we enter the world of the cocktails.
The alphabet soup. ABVD, BCOP, ChemoPP. Why do we combine these drugs? Why not just give one really, really strong drug?
It's all about attack vectors. Cancer cells are smart, they're adaptable, they can develop resistance to a single agent fairly quickly.
Okay.
But by hitting them with 4 or 5 different drugs simultaneously, drugs that attack different parts of the cell cycle or use different mechanisms of action, you completely overwhelm the cancer's ability to adapt and survive.
Let's break down the workhorse regimen then. ABVD, what's in that mix?
Okay, so A stands for adriamycin, which is the trade name for doxorubicin. B is bleomycin. V is vinblastine. And D is dacarbazine. This 4-drug regimen has been the standard of care for decades.
And what's the schedule like for that? How often do you get it?
Typically every 28 days. You get an infusion on day 1 and day 15 of that cycle.
And how long does treatment last?
It depends on the stage. If you have early stage disease, you might just do 2 to 4 cycles, often followed by a little bit of that involved field radiation. If it's advanced, you're looking at 6 to 8 cycles of chemo alone.
But there are other options. The source material mentions Stanford V.
Stanford V is an interesting one. It was developed at Stanford, obviously, to be shorter, but more intense.
More condensed.
Exactly. It's a 12-week course. And it uses a very complex mix: doxorubicin, vinblastine, mechlorethamine, etoposide, vincristine, bleomycin, and prednisone. It basically throws the kitchen sink at the cancer, but does it in a condensed time frame to try and limit the long-term exposure and toxicity.
And then there's the really scary sounding one, BCOPP.
BCOP is the heavy artillery. It's a German regimen. It adds cyclophosphamide and procarbazine to the mix.
So even more drugs.
More drugs. And there's an escalated dose version that is so toxic to the bone marrow that you have to give the patient growth factors, GCSF, just to keep their white blood cell count from hitting absolute 0.
So when would you use something that intense?
We usually reserve this for patients with advanced disease who have a number of unfavorable prognostic factors. We're willing to accept the higher toxicity because the risk of the cancer killing them is higher. It's a risk-benefit calculation.
I notice MOPP is listed as historical. Why did we stop using it if it worked?
MOPP was the pioneer. It was the first combination chemotherapy that proved Hodgkin could be cured. It was a landmark. But
But
it contained two drugs, meclorethamine, which is a nitrogen mustard derivative, and procarbazine. These drugs were notorious for causing permanent infertility and a very high rate of secondary leukemia years later.
I see.
ABVD was shown to be just as effective, but much, much safer in terms of fertility and that secondary leukemia risk. So MOPP was retired.
And that leads us directly to this idea of the cost of cure. We are saving the patient's life, but what are we leaving them with for the next 50 years?
This is the conversation that every oncologist hates having, but absolutely must have with every young patient.
I can't imagine.
The source material lists three major long-term complications. First, and this is a huge one, is gonadal dysfunction, infertility.
For a 25-year-old patient, that's devastating.
It is. So we have to have a serious conversation about sperm banking or egg preservation before the first drop of chemotherapy even goes in.
Okay, what's second?
Second is cardiac disease. Doxorubicin the A in ABVD is cardiotoxic. It can weaken the heart muscle, leading to congestive heart failure, sometimes decades after the treatment.
Decades later.
Yes. And on top of that, radiation to the chest can damage the coronary arteries. So you cure their lymphoma at 20, but they die of a massive heart attack at 50.
And the third one, paradoxically, is cancer.
Secondary malignancies. The treatment itself is carcinogenic. The chemo and the radiation can cause new cancers to develop down the road.
Like what kind of cancers?
We see higher rates of leukemia, lung cancer, breast cancer, especially in women who had chest radiation as teenagers, and various GI cancers.
That is the ultimate cruel irony.
It is. And that's why the modern strategy is shifting so hard toward response-adapted therapy. We do a PET scan after 2 cycles. If it looks clean, maybe we drop the bleomycin, which harms the lungs. Or maybe we skip the radiation entirely. We are constantly trying to peel back the therapy to the bare minimum needed for a cure.
What happens if it doesn't work? If the cancer comes back after all that?
We call that salvage therapy. If a patient relapses, especially if it happens within a year of finishing treatment, standard chemo isn't going to cut it. We need a factory reset.
This is the autologous stem cell transplant.
Right. And autologous is the key word. It means the stem cells come from yourself.
So how does that work?
The process is incredibly intense. First, we give you medications to stimulate your bone marrow, and we harvest your healthy stem cells from your blood. We freeze them.
Right.
Then we give you a dose of chemotherapy that is so high it would normally be lethal because it permanently destroys your bone marrow. This is designed to wipe out every last cancer cell.
That sounds terrifying.
It is. And then, after that mega dose of chemo, we thaw your stem cells and we infuse them back into your body. They find their way back to the bone marrow and rescue you. They rebuild your entire immune system from scratch.
It sounds like science fiction, just rebooting the human body.
It effectively is. It is very high risk, very high reward. But for relapsed Hodgkin, it's the best and often only shot at a second cure.
Okay, that wraps up Hodgkin. We have a clear enemy in the Reed-Sternberg cell, a standard playbook, and a really high success rate, albeit with some costs.
Right. It's a relatively tidy story as far as cancer goes.
No. We have to cross the divide to non-Hodgkin lymphoma NHL.
And here, the neat and tidy story completely falls apart. If Hodgkin is a well-organized, predictable army, non-Hodgkin is a chaotic, sprawling insurgency.
The notes define NHL as a monoclonal proliferation of malignant B or T lymphocytes. But the classification system seems endless.
It is huge. The World Health Organization, the WHO, classifies these based on so many factors. Cell type, is it a B cell or a T cell? Cell size, genetic markers, clinical behavior. There are dozens and dozens of subtypes.
That's overwhelming.
It is. But for the sake of our listener, the most useful way to think about NHL is by its speed. We categorize them as either indolent or aggressive.
And this leads to what I was calling the lymphoma paradox when I was reading the notes. Because looking at the prognosis, it feels completely backward.
It does. It's very counterintuitive. Let's break it down. Indolent lymphomas are slow-growing. They're lazy. If you do absolutely nothing, the patient will live for years, sometimes many years.
Which sounds good. That sounds like the one you'd want.
It sounds great. But because the cells are dividing so slowly, chemotherapy, which, remember, targets rapidly dividing cells, doesn't work very well. You can treat it, you can knock it back, you can put it into remission, but it almost always comes back. So indolent lymphomas are generally considered incurable.
So you live with it.
You die with it, not necessarily of it, but you have it forever.
Okay. And aggressive lymphomas.
They are the opposite. They grow incredibly rapidly. Without treatment, survival is measured in weeks or months. It's an explosive disease.
That sounds terrible.
It is, but because those cells are dividing like crazy, they are incredibly vulnerable to chemotherapy. We can nuke them. So aggressive lymphomas, while very dangerous, are potentially curable.
So you can either have a slow disease you can't cure or a fast disease that you might be able to cure.
Pick your poison. That is the fundamental trade-off in the world of NHL.
Does NHL present differently? Is the lump different from Hodgkin?
Clinically, it can be similar, painless, rubbery nodes, but NHL is much, much more likely to be extranodal.
Meaning it shows up in places that aren't lymph nodes.
Exactly. It likes to pop up in all sorts of strange places. We see it in the stomach, which we call gastric lymphoma. We see it in the skin, the brain, the thyroid, the testes. It's much less predictable.
The notes mention GI involvement specifically as a common site.
Very common. Patients can present with nausea, vomiting, a bowel obstruction, or even bleeding. If you have a lymphoma mass growing in your small intestine, it can cause a complete blockage.
And it affects the bone marrow more often, too.
Much more often. So you see more significant drops in blood counts. Anemia from low red cells, neutropenia from low white cells, which raises infection risk, and thrombocytopenia from low platelets, which causes bleeding.
Let's talk about treatment, and let's start with the slow one, indolent lymphoma. The source focuses on follicular lymphoma as the classic example.
Follicular lymphoma is the quintessential indolent B-cell malignancy. It usually affects older adults, people in their 60s, and it has a very specific genetic fingerprint.
Right, the translocation.
The chromosomal translocation between chromosome 14 and 18. We call it 14-18.
And the trajectory of this disease is weirdly unpredictable.
Very. One of the strangest things about it is that about 20 to 30% of patients will experience spontaneous regression. The cancer just shrinks on its own for a while without us doing a single thing.
That must be so confusing for a patient.
It is.
So if it's incurable but slow, and treating it early just exposes you to toxic side effects, do you even treat it right away?
That is the incredibly controversial concept of watchful waiting, or as some patients have bitterly called it, watch and worry.
I can imagine the psychological toll of that. Doctor, I have cancer. Yes, you do. Okay, what are we going to do about it? Nothing. We'll see you in 3 months.
It is a very, very hard thing for patients to accept, but the data for decades has supported it. Multiple studies have shown that hitting an asymptomatic, low-burden follicular lymphoma with aggressive chemo early on does not extend overall survival compared to waiting until symptoms appear.
So why put them through it?
Exactly. Why give someone heart damage or nerve damage today if they might feel perfectly fine for another 5 years without any treatment at all?
But eventually, you do have to treat. What are the options when the time comes?
When symptoms arise, like bulky, uncomfortable nodes, the B symptoms we talked about, or if it's pressing on an organ, then we step in.
And what do you use?
We have a lot of options. We have single-agent oral chemotherapy like chlorambucil or cyclophosphamide. They're mild, low toxicity. Then there are the adenosine analogs like fludarabine. These are more potent, but they cause profound, long-lasting immunosuppression. Patients on fludarabine can get opportunistic infections like they have AIDS.
So a big risk.
A very big risk.
But the real revolution here wasn't a chemotherapy drug at all. It was an antibody.
Rituximab. This single drug completely changed the face of lymphoma treatment.
How does it work? It's not chemo.
It's not. It is a chimeric monoclonal antibody. Basically, it's a lab-made biologic missile designed to target one specific thing, the CD20 antigen.
And what's CD20?
CD20 is a protein that is found on the surface of almost all B cells, both normal and malignant.
So it's a homing beacon for B cells.
It is a perfect homing beacon. Rituximab enters the bloodstream, it finds anything with CD20 on it, and it latches on. This acts like a flag, telling the patient's own immune system to come and destroy that cell. It recruits the body's natural killer cells to do the dirty work.
And since follicular lymphoma is a B-cell cancer,
it works beautifully. We use it as first-line therapy, sometimes all by itself, sometimes combined with chemo. We even use it as maintenance, where we give a dose every few months for up to 2 years to keep the disease suppressed.
And the side effects?
So much better than chemo. You can get some infusion-related reactions, fever, chills, maybe some angioedema, but you don't lose your hair, you don't vomit, you don't get the marrow suppression. It's a game changer.
The notes also mention radioimmunotherapy. This sounds like the next evolution of that idea.
The smart bomb. This is fascinating technology. They take an antibody that targets CD20, just like rituximab, and they chemically attach a radioactive isotope to it, usually iodine-131 or yttrium-90.
So the antibody delivers a dose of radiation directly to the tumor cell.
Precisely. But it gets even better. It has what's called a crossfire effect. Once the antibody binds to the tumor cell, the radiation doesn't just kill that one cell, it radiates outward a few millimeters, killing the cells next to it as well.
Why is that so important?
Because sometimes not every single tumor cell expresses CD20, or the antibody might not be able to penetrate deep into the center of a big, bulky tumor mass. The radiation crossfire cleans up the neighbors, even if the antibody didn't latch onto them directly.
That is ingenious. Is there a downside?
Of course. The main one is bone marrow toxicity. You're still delivering radiation. And with the iodine-131 version, you have to worry about the thyroid, which just loves to absorb iodine.
So you could damage the thyroid.
You could. So you have to medically block the thyroid with medication beforehand so you don't accidentally radiate it into oblivion.
Okay, that is the slow road. A fascinating, complex road. Now let's switch gears to the fast lane. Aggressive lymphoma. Specifically, diffuse large B-cell lymphoma, or DLBCL.
This is the most common type of lymphoma in the entire world. It tends to peak in people in their 60s and 70s, and watchful waiting is absolutely 100% off the table here. If you wait, the patient dies.
So we attack immediately. What is the weapon of choice?
The undisputed gold standard is a regimen called RCHOP. That is rituximab plus the CHOP chemotherapy regimen we mentioned earlier.
Right. Cyclophosphamide, doxorubicin, vincristine, and prednisone.
That's the one.
It seems like rituximab is the secret sauce for everything B-cell related.
It truly is. Adding rituximab to the CHRP regimen significantly improved survival rates compared to giving CHOP alone. It was a massive leap forward.
And the treatment plan depends on the stage.
It does. For localized disease, say stage 1, we might just do 3 or 4 cycles of RCHP plus some radiation. For advanced disease, stage 3 or 4, it's a full 6 to 8 cycles of RCHOP.
And unlike with follicular lymphoma, we don't do maintenance therapy here.
Correct, and that's a key point. With aggressive NHL, this is cure or bust. Once the patient achieves a complete response, meaning the PET scan goes completely dark, we stop. Maintenance therapy has not been shown to provide any benefit. You hit it as hard as you can, you kill it, and you hope it stays dead.
What if RCHOP fails? The notes say about a third of patients don't get a cure on the first try.
Then we are back in the world of salvage therapy, but the acronyms change. We use regimens like DHHP, ESHAP, MINE, and a very popular one in the U.S. is called ICE.
IC. Iphosphamide carboplatin, etoposide?
It's a platinum-based regimen. It's tough, but it's often better tolerated in elderly patients than some of the other salvage options.
And the goal of ICE is to get to transplant.
That's the only reason to do it. The goal of salvage isn't just to manage the disease. It is to get the patient into a deep enough remission to be a candidate for that high-dose chemo and autologous stem cell transplant we talked about with Hodgkin. That is the only real hope for a cure in relapsed aggressive lymphoma.
We are in Section 5 now, and we need to highlight a specific population that faces a unique nightmare with this disease. Patients with AIDS.
This is a critical intersection of infectious disease and oncology. Patients with AIDS have a more than 100-fold increased risk of developing non-Hodgkin lymphoma.
100-fold. That is an astronomical number.
It's staggering, and it's almost always the aggressive types, Burkitt lymphoma or
Right.
DLBCL. The mechanism is complicated, but it's partly the profound immunodeficiency and partly co-infection with other viruses like EBV or HHV8.
The treatment challenge here seems obvious. To treat aggressive lymphoma, you need to use chemo that wipes out the bone marrow. But an AIDS patient is already severely immunocompromised.
That's the crux of the problem. If you give standard RCHOP to a patient with a very low CD4 count, the toxicity can be lethal. They die of overwhelming infections. But you can't not treat the cancer because it will kill them in weeks.
You're between a rock and a hard place.
Completely. Standard CHOP often yields really disappointing results in this population. But there are newer approaches. The notes mention a regimen called dose-adjusted EPOCH.
EPOCH, another acronym.
It is. It stands for etoposide, prednisone, vincristine, cyclophosphamide, and doxorubicin. So similar drugs. But the dose-adjusted part is the key.
What does that mean?
Instead of giving a fixed dose, The doctors measure the patient's blood counts after every single cycle, and they titrate the next dose up or down based on the counts. It allows them to push the chemo as hard as that specific patient can tolerate without completely destroying their immune system. It's personalized.
And they have to stay on their HIV meds during this.
Usually, yes. But the drug interactions between heart, the antiretrovirals, and chemotherapy are an absolute nightmare. You have to be incredibly careful with liver enzymes and drug metabolism. It's a very fine line to walk.
Before we wrap up, let's talk about crystal balls.
Mm-hmm.
How do doctors predict which patients are going to do well and which ones are likely to struggle?
We use something called prognostic indices. For aggressive lymphomas, the big one is the IPI, the International Prognostic Index. It's basically a scorecard.
Okay, what's on the scorecard? What are the factors?
There are 5 key factors. Number 1 is age being over 60 is a negative point. 2 is performance status. Basically, how well can you function? Can you walk, work, feed yourself? 3 is your LDH level.
Lactate dehydrogenase.
Right. High levels of LDH in the blood indicate a lot of tissue damage or a high tumor burden. 4 is the number of extranodal sites, and 5 is the stage 3, or 4 is worse.
So the more of those risk factors you have, the worse your outlook.
Correct. It helps us stratify patients into risk groups. If you have a very high IPI score, we might say, standard RCHRP probably isn't enough. We should send you straight to a clinical trial for a more intense regimen because we know the standard path is likely to fail.
So we've covered the biology, the staging, the alphabet soup of treatments, the special populations. It is a lot to synthesize.
It is, but I think if the listener takes one single thing away from this, it should be the incredible diversity of this disease. Lymphoma isn't a diagnosis, it's a category.
Right. On one end of the spectrum, you have the indolent follicular patient, where the doctor might literally say, go home, live your life, we'll see you in 6 months.
And on the other end, you have the aggressive DLBCL patient, where the doctor says, you're being admitted to the hospital now, and we are starting chemo tomorrow.
It's the same family of disease, but they are completely different realities for the patient. And looking at the history, the evolution of treatment is pretty remarkable. We've moved from the blunt force of the MOPP regimen, which, yes, it cured people, but it left them sterile and prone to other cancers.
To the incredible precision of something like rituximab.
Exactly.
We are getting smarter. We are moving from carpet bombing to sniper fire. But that provocative thought that we started with, it remains the trade-off. We are constantly balancing the aggressiveness of the cure against the long-term quality of life.
The cost of cure.
Yes. Secondary malignancies, cardiac disease, infertility. These are the prices that are paid for survival. And as we get better and better at curing the lymphoma itself, the population of survivors who are living with these long-term side effects is growing.
So managing the aftermath of the battle is becoming just as important as the initial fight.
In many ways, yes, it's a lifelong journey for these survivors.
It really emphasizes the importance of knowing your enemy. You can't just fight cancer. You have to know the exact histology. You have to know if it is Hodgkin or non-Hodgkin, indolent or aggressive, a B cell or a T cell.
That initial biopsy slide is the most important roadmap in the patient's entire journey. Everything, the drugs we choose, the prognosis we give, the risks we discuss, all of it follows from what the pathologist sees in that microscope.
Well, I feel like we have successfully navigated the alphabet soup. It is an incredibly complex field, but understanding that basic split, that great divide, makes it so much easier to understand the news and the research that comes out.
Absolutely. It's a deep field, but a truly fascinating one.
Thank you for walking us through it. And to our listener, we hope this deep dive gave you a clear map of a very complex territory. As always, keep asking questions and don't settle for the surface level explanation.
See you next time.
We will see you on the next deep dive.